This is A Better Night's Sleep, a podcast about sleep, sleep disorders, and evidence-based treatment from Military Health System sleep experts. I'm Dr. Julie Kinn with the Defense Health Agency.
And I'm Dr. Jonathan Olin, sleep physician and medical director of the Evans Army Community Hospital Sleep Lab.
So, John, today we're going to be talking more about sleep studies. Now, you corrected my misconception, which is a sleep study is not research about sleep. It's a study that takes place in a lab to help diagnose sleep apneas and other disorders, correct?
Right. So this is generally done or can be done in an in-lab attended sleep study, or now, to some extent increasingly, they're done in a person's home in their bed, where they'll take equipment home.
So give us a beginner's look at what happens in a sleep study. What happens when I get to the lab? Is anything going to hurt?
Good questions. In general, the main thing, the most common thing that people are looking for with a sleep study is there is a sleep disorder breathing condition. For example, obstructive sleep apnea. So they'll have often signs or symptoms of sleep disorder breathing. For example, progressively and getting louder snoring. Observed apneas where they're gasping or choking at night and their bed partner says, "I'm concerned." And often combined excessive daytime sleepiness where they're tired during the day, prone to falling asleep during the day, in meetings, at lunch, when reading. And so some combination or all of those things could be suggestive of obstructive sleep apnea, so they'd be referred then for a sleep study.
So sleep studies are just for diagnosing sleep apneas? They're not for insomnia or other disorders?
Generally, you do not do a sleep study for insomnia or quote uncomplicated insomnia only. We don't do them only for sleep apnea. While the person is in the lab, for example, we'll hook up. They'll have a number of electrodes, basically from head to not quite toe, but to leg. And each electrode, they're pasted on, so that it's not painful. But each electrode or each wire will give information. So wires on scalp, for example, will show us, are they asleep or are they just resting quietly with their eyes closed?
But isn't it hard to sleep if you have wires on your head and body?
Yeah, for sure. For many people will say, wow, that was a tough night's sleep. It is often hard to sleep in a sleep study compared to at home. We do have some people that go, oh, I slept better in this sleep study than at home. And that may be suggestive of what's called psychophysiologic insomnia, where we earlier in previous podcasts talked about how people kind of become Pavlovian and trained, or where their bed and bedroom is where they have insomnia. So you take them to a different environment, even with wires all over on their scalp and bands around their chest and abdomen, and they're like, oh, different environment. I'm not used to this. Okay, yeah, I can go to sleep.
Mm-hmm.
So we're not saying that this will totally replicate an average night's sleep at home, but we do need to have some data before we can make a diagnosis, some conclusive proof to demonstrate that they have sleep disorder breathing. So they'll have wires on their scalp, as indicated, to demonstrate that their brainwaves of sleep, wires around their nose and mouth to see if they're moving air, and then bands around their chest and abdomen to see if there's an effort to breathe. So obstructive sleep apnea would be brainwaves of sleep, not moving air, and then an effort to breathe with chest and abdomen moving, expanding, contracting, but obviously a blockage or an obstruction. So that's obstructive sleep apnea. Central sleep apnea would be the exact same on a sleep study, with the significant difference of no effort. So no effort to breathe. So brainwave sleep, not moving air, but no effort. In general, or not in general, an apnea we consider substantially less air movement for a period of 10 or more seconds. So,
oh, wow.
Yeah, so if someone's missing a breath for 3 or 4 seconds or 5 seconds, we're not going to count that as an apnea. So these are, missing actual breaths. These are for adults.
How many times a night is that happening?
If someone's having up to 5 events an hour, we call that normal.
Oh.
So in the sleep field, we don't demand perfection, that they must never have any kind of obstruction or never have any kind of scorable event. So we'll call up to 5 normal. 5 to 15 we'll call mild if there are other ongoing symptoms. For example, insomnia, hypertension, cardiac problems. Then that would be obstructive sleep apnea with other symptoms and, say, 10 or 12 events per hour. 15 to 30, up to 30, we call moderate obstructive sleep apnea by the frequency of the events. And more than 30, we call severe. There's a gradation or continuum of severity by the frequency of events. Obviously, someone could have 19.9 or 29.9 events per hour and have events that are 20 or 30 seconds long.
Oh, my gosh.
And really dropping their oxygen very significantly. So by frequency criteria, that would be considered moderate, but by dropping the oxygen criteria, that could be called severe.
And I would imagine someone who has such severe events would really be feeling fatigued the next day.
Mostly they are. There are people that say, no, I feel great. It's my bed partner that has a problem. I don't know what they're talking about. I'm sleeping great. But mostly they are because oxygen's a good thing. So someone that's during the day blocking, occluding, snorting, gasping, missing breaths 30 times an hour and dropping their oxygen significantly, they're not going to be feeling very good during the day and struggling with their concentration, with their memory, with their attention.
I can see this as a safety issue, especially if the patient isn't recognizing that they are sleep deprived, or if the partner isn't pointing it out, or for people who live by themselves. It seems like it would affect driving, on-the-job issues, other safety factors too.
True. So probably most people are actually undiagnosed for really a period of years, and and it reaches a point where they then are evaluated and then start treatment. And many, in my personal experience, most people, not immediately, and we'll talk about treatments in a minute, but they'll say, wow, I didn't realize how sleepy I was. I didn't realize how fragmented or impaired my sleep was, and now I'm feeling so much better. It does take a period of adjustment for some of the treatments, including positive airway pressure, PAP, which we'll talk about. So I'm not saying that these are like first day of penicillin and immediately you feel better, or, first night of treatment with treatment, you feel immediately better. But yeah, oxygen's a good thing. Continued sleep's a good thing. There's a lot of data about strokes, about hypertension, about car accidents with untreated apnea. And as it's treated, these things can begin to normalize, including, for example, car accidents, because people are so sleep deprived and sleepy with untreated apnea. And as it's treated, they can continue to normalize.
What are some of the predictors of sleep apneas? The only one I'm aware of is being overweight. I think that one's pretty common in media. Are there others that we should be watching out for?
Sure. So male is a predictor, or male is increased risk.
Oh, really?
Big neck, 18 or above for male, 17 or above for female. Overweight, although that's not a hard and fast rule, but overweight, and frankly, double chin, that kind of thing. So someone who, most of us are vertical right now, the people, our listeners, and hopefully I'm not too boring, so they're awake and they're vertical and their airways open. When they go to sleep at night, they're obviously generally horizontal, their muscles are more relaxed, and then their airway may close. So they'll breathe in, pulling in through their diaphragm, which is a muscle between their chest and their abdomen. As that contracts, it pulls air in. If their airway is prone to collapse, it'll collapse generally with the inspiration. If someone has a double chin or a triple chin, there obviously is a little bit more weight on their neck, and then maybe that much more prone to collapse. Their tongue might be slightly bigger too. Some people are totally normal weight or even underweight. That could be severe obstructive sleep apnea.
Oh, really?
It's not by any means an absolute, necessity. Weight gain can assist with making it more likely. Menopause for women, I realize that's, there aren't that many menopausal women just numbers-wise in military. But as women become postmenopausal, their rates catch up to men. So there appears to be some protective hormones, female hormones for apnea. Obviously, family history. If someone has very loud snoring and every member of their family snores and 4 of them or many of them have obstructive sleep apnea, even if they're underweight, they may be more prone to develop apnea than someone in the general population.
So you mentioned some sleep studies happen at home. How do you decide which to do in the lab and which to do at home, and what happens in the home studies?
Yeah, so home studies is an important area, and they're becoming increasingly commonly done. So home studies are not going to be generally attended. They're not going to have a sleep tech 20, 30 feet away from you with as many wires, but you're going to have several wires. So you'll have wires around your nose and mouth to look at, are you moving air? You're going to have wire probably on your finger to look at your oxygen level. And you may have a wire with a microphone to listen to snoring and evaluate body position if you're on your back or on your side. And then place this on yourself at night, go to sleep, take it off in the morning, and bring it back to the lab. And that data then can be run. In general, many people are looking at this to rule in obstructive sleep apnea. So these are people that are viewed as higher risk for having apnea. And then you have data from a home sleep test that says, yes, they do have this, and let's go ahead and treat them. It's not considered the, quote, gold standard. So if someone is viewed at higher risk and then has a negative home test, they'd be a good candidate, or it's often recommended they have an in-lab sleep test to further evaluate before you can say, yes, they don't have obstructive sleep apnea. We have an in-lab study that showed that they have good breathing.
So it's often a first step.
It can be the first step. Currently, the Army wants for active duty service members to have in-lab studies and proceed with the gold standard to clarify issues around, for example, deployability. They don't want to have a negative study and then someone be deployed far away and then be sleepy or have questions of, was that really a valid study? So currently for active duty, we're doing in-lab studies. Again, for people that are viewed at higher risk, at least in an Army setting, higher risk, say, dependents or retirees, we could consider doing home sleep testing. And again, if they're positive on that, then look at treatment. If they're negative, be brought into a lab for testing to be more conclusive.
Is there any advice you'd give to patients before they come in for their sleep study? What would you want them to know?
We're really interested in them sleeping. So it's not a question of, are they going to, breathe well when awake? We know generally people do that. They're not going to be on an outpatient if they're struggling to breathe when awake. So we're really interested in sleep time. So that means hopefully be comfortable. So bring pajama top and bottom that they're comfortable with, bring their own pillow, reduce their caffeine, obviously avoid evening caffeine. If they're being treated for insomnia, hopefully get into a bit of a cycle or pattern where they're sleeping relatively well at night. A sleep study could be a setting where use of a sleep med may be appropriate or could be considered. Previous podcasts we talked about it not being a good long-term solution, but if someone's struggling to sleep in a lab, one night of sleep medication may be appropriate or may be considered. So they can review that with their clinician before coming to the sleep study. The sleep lab generally will give instructions, obviously where they are, when to arrive, caffeine. Most labs will have bathrooms nearby. There'll be a changing area or dresser.
Wait. I should have asked this immediately, but how do you go to the bathroom with all the wires attached?
That's a good question. So the wires are attached to a box, and then you can just unattach the box from a main channel or kind of cable, if you will, and you'll carry that around. So rather than undo all the wires, say from a person's scalp are then plugged into a box, and then so you can then unplug the box. It's maybe the size of ballpark a couple, 3 cell phones put together, average size cell phone. So it's not like you're carrying around a file cabinet.
Okay.
So then when they return from the bathroom, that box can then just be plugged into a cable, and then all the information can be continued. can continue to be recorded.
I could see that being a good reason to not have beverages beforehand.
Not a good time to have 4 coffees before going to the lab, even if you sleep well with caffeine. Earlier, you'd asked about sleep disorder breathing or obstructive sleep apnea, the only thing that's tested for. So while someone's in the lab, it's a full night, there's a sleep tech there. There are going to be other things that are monitored, for example, their EKG, and I talked about their breathing effort. We'll also put a lead on each leg, and that's evaluating for if they're kicking or moving during the night.
Oh.
And there are things called periodic limb movement disorder and another condition called restless leg syndrome, RLS. And with both of those, we'll often see leg movements during the night. Is that very, very commonly done as the reason for the sleep study? No, but while they're there, we're going to take advantage of looking at them in a comprehensive manner, at least for the in-lab study.
John, thank you so much for telling us about sleep studies and how you generally go about diagnosing sleep apneas. I'm looking forward to our next episode when we talk about treating sleep apneas. Thank you, listeners, for joining us as well and for sending us your feedback. A Better Night's Sleep podcast is produced by the Defense Health Agency. You can get in touch with us to let us know what your sleep questions are at Military Health on Facebook and Twitter. Thank you so much for subscribing and rating us on iTunes or wherever you get podcasts. Remember, even though we make this for the military community, everyone can use a better night's sleep.